Good afternoon, and thank you for joining the Skin Cancer Awareness Panel. My name is Sean Kenny with Dignity Health, and today we will have Dr. Fernandez, dermatologist with CBCC, and Dr. Pugalente, a general surgeon and oncology surgeon with Dignity Health. And the format for today is we're going to provide a brief presentation on skin cancer, and then at the end we will have an open Q&A session. So please remain on mute and ask your questions in the chat. So with that, let me make sure I've got all the housekeeping out of the way. And again, just a reminder that this is being recorded, and if you registered, you will receive a recording of this along with the transcript with the questions. So that will be sent to the email that you had registered with. So now, again, I'd like to introduce Dr. Fernandez, dermatologist with CBCC, and Dr. Pugalente, oncology surgeon with Dignity Health. Doctors?
Hi, and good afternoon, everybody. Thank you for joining us today. I am Dr. Fernandez and Dr. Pugalente.
Hi, good afternoon.
And today what we're going to focus is on skin cancer awareness. Just briefly, just a few things about me. I graduated in Rutgers Medical School about 20 years ago. I'm a board-certified dermatologist, also a board-certified micrographic dermatology surgeon. And I practice here at CBCC, and I also have a practice down in LA called Beach Cities Dermatology. And Dr. Pugalente?
Hi, I'm a general surgeon and fellowship trained in surgical oncology. I've been in Bakersfield for the past 3 years. I'll answer your questions regarding surgery for cancer, skin cancers today. Over to Dr. Fernandez today.
Great. The reason why we're doing this today is because May is the Melanoma Awareness Month, and skin cancer is a very common form of cancer, but it's actually one of the most preventable cancers. And this is what we want to focus today, is the discussion on prevention, the early detection, and also its treatment. So we also want to identify some myths about sun exposure and about tanning, and we'll go into a few details about the different types of skin cancer. And I'll briefly also mention, if we have time, some facts about different types of sunscreen. So with that, I want to start this talk with just a few questions that I asked before the presentation, and then I will go over those questions at the end to see how much your knowledge change as we go through the whole entire presentation. So the first question is, which is the most common cancer in humans? And you have breast cancer, skin cancer, lung cancer, and colon cancer. Question number 2 would be, how much vitamin D does indoor tanning produces? And there are your choices. So some people believe that if you do it slowly and safely, you could actually get a good amount of vitamin D, or B, you get sufficient amounts of vitamin D after 15 minutes, or indoor tanning using UVA is safe and produces sufficient amount of vitamin D, or D, indoor tanning does not produce any amount of vitamin D. Question number 3 is, which is the most common type of skin cancer? And the choices are basal cell, squamous cell, malignant melanoma, and cutaneous T-cell lymphomas. Question number 4 is the sun rays wavelength. Which one is the one responsible for sunburns? And you have UVA, UVB, UVC, or infrared rays. And finally is, what are your chances of, in your lifetime, of developing skin cancer? 1 out of 10, 1 out of 8, 1 out of 5, or 1 out of 3 Americans will develop skin cancer. So think about your choices, and we'll review them at the end of the lecture. Okay, so discussing skin cancer is by far the most common type of cancer in humans. And the way we divide it is into melanoma skin cancers and non-melanoma skin cancers. And the treatment is quite different, and the prognosis is also different. So that's why we kind of divide the melanomas and the non-melanoma skin cancers in two big groups. The second most common cancer is lung cancer, prostate cancer, follows the breast cancer, colorectal cancer, and then kidney cancer. Those numbers keep changing every year, and but these are the latest statistics on that. The key thing is prevention. Like I mentioned before, skin cancer, although it's very, very common, prevention is key because it's one of the most preventable cancers in humans. We always, as dermatologists, we always say that you need to seek shade. Shade is actually one of the most important ways to protect you against the harmful rays from the sun. The sun rays are more harmful during the times of 10 a.m. to 2 p.m. And that's mainly because most rays are made out of UVA, but UVB actually increases in percentage during 10 and 2 p.m. And UVB is one of the most high energy harmful rays that you could have, which is actually what leads to sunburn. The other thing besides seeking shade is to wear your sunscreen. You should actually wear a broad spectrum sunscreen, one that is water resistant, one that is an SPF of 30 and above. And then something that is sometimes gets overlooked is protective clothing, long sleeve shirts, hats, sunglasses, pants. Those things are very, very important to preventing skin cancer. The other thing that is important to mention is the protection of your lips. And you will see a few pictures of some of my patients that they end up with a significant amount of skin cancer on their lower lip, because as you protect your skin, you always forget to protect your lower lip. And that you do need to use some chapsticks that contain some SPF so that you could protect your lower lips from future skin cancers. So detection. Early detection is key to any treatment of any cancer, and so much more when it comes to skin cancer. The reason why is skin cancer, obviously the skin is an organ that you could see, and it is easier for you to detect if there's something wrong with the skin. You don't need a colonoscopy to look at the skin. You don't need any CT scans. We could look at it every day and kind of try to identify if there's something normal or abnormal with the skin. So skin cancer is highly treatable if detected early, including malignant melanoma. There is a website that is called spotskincancer.org that actually trains you, teaches you what to look for. I usually tell my patients to try to spot the ugly duckling, anything that looks somewhat different than the other lesions. If the lesion is new, if it's changing, if it's bleeding, if it's itching, no lesion should last in your body longer than a couple of weeks, 2 or 3 weeks. Pimples normally do not last a month. I have a lot of patients that come in with a bleeding pimple that has been there for many, many months. Pimples do not last more than a few weeks. The other thing that we try to train our patients is to learn the ABCs of melanomas. And that, let's see what happened there. All right, let's see here. Okay, so the keys to the ABCD rules of melanoma is A is for asymmetry. Here in the picture, you could see a malignant melanoma. This one is an AC case because it has all the A, B, C, D, E's of the melanomas. So it has a symmetry where if you split it in half, half of the lesion looks different than the other half. The borders are irregular. The colors are multiple shades. They could be red, it could be brown, it could be black. The diameter is usually bigger than a pencil eraser. Although as dermatologists, our job is to actually spot a melanoma way before any of these A, B, C, D, E rules become obvious to our general population. I always say that if the general practitioners or your significant others sees that a melanoma looks or a lesion looks highly suspicious, that's usually a little bit late. So we want to actually, we dermatologists, we are trained for many years to spot the melanomas when they're only a few millimeters in size. And then the other thing is the E. It goes for evolution. How is the lesion, that lesion evolving? Is it changing? Is it different than all the other lesions? So those are key for you to spot significant or suspicious lesions that you should bring to the attention. So the American Academy of Dermatology shows in their websites how to actually remember the ABCDs of melanomas, and also how to perform a skin cancer self-examination. And that is very important because, again, early detection starts with you realizing that there is something that doesn't look right. So one of the things that we always want you to do is to maybe once every 2 months or maybe even once a month is for you to look yourself in the mirror and to use the front of the mirror. You want to check the front, you want to check your back, you want to check the back of the legs, you want to look at your elbows, you want to look at the axillas. The bottom of the feet is important, right? You could actually get malignant melanoma in areas that you never had sun. I always tell my patients about the story about Bob Marley that died of a melanoma on his toe. So you want to check also at the bottom of your feet. You want to get a hand mirror and examine the back of your neck, the back of the ear, and your lower back. You don't always need a partner for you to do your self-examinations. Many patients that come into the office, they are the ones that spot something wrong with a skin lesion. So it's quite important to do that. The other thing that is important is live. So we in dermatology, we say prevention, detection, and live. Live is you want to actually, if you end up with a malignant melanoma or a skin cancer, you want to actually optimize the treatment. You want to have the best chance for survival. And that's where good medical care comes in. And the earlier you seek for experienced dermatologists, surgical oncologists, and oncologists, the better your chances of survival are. For example, if your melanoma gets caught before it even shows up in the lymph nodes, and Dr. Prevalenti, he's one of the surgeons, surgical oncologists I refer my patients to when they need sentinel lymph nodes, and we'll briefly discuss what that means, is if your lymph nodes are negative and there's no melanoma found, your survival, your 5-year survival is 92%. But if your lymph nodes start to show malignant melanoma, now it drops to 65% chance of living 5 years. If that melanoma has spread to distant organs or to distant lymph nodes, then your chances of survival could be 25%. So early detection is key. The other thing that I want to mention to you about now is just is the education on what kind of skin cancer types are out there. Most patients know malignant melanoma. Most patients, when they get diagnosed with a skin cancer, they think they have a malignant melanoma, and they don't. In fact, the most common type of skin cancer by far is the basal cell carcinoma, followed by the squamous cell carcinoma. The third type is the famous malignant melanoma. And this is a very abbreviated list. There are many, many more types of skin cancers, including Merkel cells and lymphomas and sebaceous carcinomas. So we normally just tend to just focus on the top 3, but just know that there are many, many different types of skin cancer. It's just those top 3 are the most common ones. Briefly, let me mention about basal cell carcinoma, because you probably have heard of a family member or a friend who had a diagnosis of basal cell carcinoma and had surgery for basal cell carcinoma. Basal cell carcinoma, like I mentioned, is by far the most common type of skin cancer. It is mainly due to sunburns when you were younger. and it tends to present clinically with a pearly pink color lesion. If advanced, they tend to bleed. They tend not to be painful. Most of the time, they're totally asymptomatic. And in fact, these are the types of lesions that patients confuse with a pimple because they look pink, just like a pimple. They rarely spread to other organs, but they can continue to grow locally and cause significant disfigurement to the patient. And in here, I will show you just 3 of patients that I recently did surgery on. And the reason why I highlight the eyelid is to show you how important it is to wear your sunglasses. And it is not by chance that most of these skin lesions, you see them on the lower eyelid. And it is in the lower eyelid because the sun hits it from above down to the lower eyelid. The same thing with the lower lip being more involved than the upper lip when it comes to skin cancer. And this is another advanced skin cancer or basal cell carcinoma on the bridge of the nose and the distal nose. These patients get treated with most micrographic surgery, and then we do the reconstruction in the office. Again, the prognosis tends to be excellent. They tend not to require any chemo, and rarely do they require to have radiation, but again, the disfigurement could be quite significant. The second most common type is the squamous cell carcinoma. And the squamous cell carcinoma usually presents in sun-exposed areas. It's usually due to chronic sun exposure, not necessarily sunburns, just everyday sun. Very, very common in the older patients, but also squamous cell carcinoma could be found in the oral cavity, in the lungs due to smoking, and even in the private areas due to human papillomavirus. Although it is called squamous cell carcinoma, skin or cutaneous squamous cell carcinoma, they tend to behave differently than the squamous cell carcinomas you find in the lungs and in the mucosa. Those tend to be a little bit more aggressive. Cutaneous squamous cell carcinoma or skin squamous cell carcinoma does spread to other organs, unlike the basal cell carcinoma, which rarely ever does. In fact, squamous cell carcinoma is responsible for more annual death than malignant melanoma. More patients died of squamous cell carcinoma annually than they do of malignant melanoma. Not because the malignant melanoma is not the deadliest or the most lethal, it's just because squamous cell carcinoma is a lot more common than malignant melanoma is. So that's an important point. It's not just the malignant melanoma. We do need to be aware of other types of skin cancers like squamous cell carcinomas. Here are 3 patients that actually presented in my practice with squamous cell carcinoma, lower lip, 2 of them in the lower lip, and on the scalp. The one on the lower lips, they actually spread to the lymph nodes, and the squamous cell carcinoma in the middle picture of the forehead is spread into the bone. So if not treated early and ignored, they won't stop growing, and they will continue to cause significant disfigurement. These patients, I underwent surgery and they did well, but they still have a chance of not surviving because it has spread to the lymph nodes. Finally, the other type of skin cancer is the one most of you know, which is the malignant melanoma. That one is the most feared of all the skin cancers, just because it's so lethal. This is a very, very aggressive type of cancer. A lesion that is only a few millimeters in depth could actually kill the patient. These cells know how to metastasize and spread very, very early on. The melanocytes, which are the cells that gives us pigment, when we are embryos and embryological, they come from the brain or from the neural crest, and they tend to know how to migrate very, very early on to give us color to our whole body. In fact, also our eyes and our hair. So those cells, when they become malignant, they're very good at migrating and spreading to different organs. And that's why the malignant melanoma is such a lethal cancer. So it is critical for us to learn how to recognize it so that we could catch it early and have a good prognosis. My routine is whenever I diagnose a malignant melanoma, if it is stage 1A or 1B or more than 1 millimeter, I send them to Dr. Pagolanti for him to do the sentinel lymph nodes. And maybe he could briefly mention what that is. Dr. Pagolanti?
Yeah, so if for any cancer, the way we describe cancer is TNM. T stands for a tumor size, and next is the N for nodes, and the last EM is for metastasis. So any cancer, we initially look at the size. Is it already spread to the local lymph glands? For example, arm, the lymph glands are present in your armpit. And the last thing is they spread beyond the lymph glands, like from the armpit, they have already gone into the chest or liver or any other organ, including the brain. So we tend to assess the risk of patient getting a lymph gland involvement based on studies done in the past. So any tumor which is larger in size, for example, melanoma, it's not the size is the depth. For any other cancer, the size is like 2 centimeter, what we look from outside. But for melanoma is the depth. The dermatologists take an initial biopsy and see how far it has gone. So for melanoma, anything above, we are looking at millimeters, not even centimeters. So you have to imagine how serious we're talking about the depth. It's anything about 0.8 millimeters with ulceration, like that's a bad quality in a melanoma, or anybody above 1 millimeter, they are high risk for involvement of the local lymph glands. So we try to test the lymph glands are involved. What we do is in the office, we try to clinically examine with our fingers, see if the lymph glands are enlarged. And then if they're enlarged, we do an ultrasound and put a needle in it to see if the cancer cells are already spread in the lymph glands. The other way to do it is if we don't feel any lymph gland enlargement in the office, we don't have any suspicion based on the ultrasound of the lymph glands. What we do during surgery, if there's an indication to do a sentinel lymph node biopsy based on the size or based on the features like ulceration, if there's an ulcer in it, what we do in the operating room before we excise the primary lesion of the skin, we do inject a blue dye. And the day before surgery, we ask the nuclear medicine experts to inject 1 millicurie of a nuclear material around the tumor. And what happens is the lymph glands are very good. They prevent infection. They act like filters. So what happens after the tumor tries to spread to the lymph glands. The same principle we catch to inject a blue dye during surgery. And the day before surgery, we ask the nuclear medicine doctors to inject a nuclear material around the tumor. So the next day during surgery, we also inject a blue dye, and we try to make an incision in the armpit. For example, if the lesion is in the arm, we make an incision in the armpit and use a gamma detector to see the beeping sound of the nuclear material in the lymph glands, and also look for the blue dye at the same time that we inject in the operating room. So 2 methods so that our sensitivity of detecting the right lymph node, which is cancer cells, is high, close to 99%. So we take the sample and send it to the pathology. In that way, we are like, our error is less than 1% to miss it going to the lymph glands. And that is called a sentinel lymph node biopsy that is done in the operating room. We combine that procedure with the removal of the primary tumor in the skin with a wide margin depending on the depth of the lesion. We remove normal skin around the tumor based on the depth. It depends 1 centimeter, 2 centimeter, which creates a defect, and then we close the skin and we remove the primary tumor as well.
That's right, great. And then the key to what Dr. Pagolanti mentioned is when we categorize malignant melanoma, we are actually basing it on millimeters. So something that is thicker than just a wristband and a watch, is actually that thickness is quite dangerous for a malignant melanoma. And at that point is where we actually send the patient to see the status of the lymph nodes, because the chances of that melanoma have already spread and become a stage 3 melanoma, it's usually at least 20%. So it is important, again, to detect the skin cancer early, because the medications, so the chemo medication that we currently have for melanoma, it has improved tremendously with the new medications called immunologics, and these drugs like Keytruda, they train your immune system to attack the melanoma, but still the prognosis and the survival is not as good as with other types of medication for the types of cancers like lymphomas or even leukemia in children that I actually have much better response. So when it comes to malignant melanoma, the key is to get to the doctor and detect that malignant melanoma before it spreads into the lymph nodes. And remember, we're only talking about millimeters in depth. So here are a few cases. This patient on the first picture, it was a melanoma that presented in close to the belly button. The picture in the middle, it's a lady who had a few months back a melanoma in the lower eyelid that was actually just a stage 1. And then the last patient is a patient that has a much more advanced malignant melanoma. And those patients will require extensive surgery and probably chemo medication or immunotherapy. And so that is the kind of the simplistic way to talk about the types of most common types of skin cancer. The other thing that I wanted to bring up in the discussion of skin cancer awareness, obviously, is sunscreens. I always get the question asked, Doc, which is the best sunscreen? And really, there is not one single best sunscreen. And I know they hate this answer, but it's the absolute truth. I want patients to stick with the sunscreen that they will use, because if they buy one that has a very, very high SPF and has amazing reviews as far as like it's very protective, but when you put it on, it feels heavy, it stings, and it smells, you're just not going to be using it. So it has to be a practical product for you to be able to every single day use it as part of your skincare. So it could be a spray, or it could actually be a light, elegant sunscreen, one that is not doesn't clog your pores, et cetera, et cetera. So I will go over a few details about different types of sunscreens. So sunscreens are divided into two main categories, mineral sunscreens and chemical sunscreens. The mineral sunscreens are the ones that contain zinc oxide and titanium dioxide. Those are the ones that sometimes they look like diaper rash cream that patients put on top of the bridge of the nose. These sunscreens, they work by blocking the rays. They used to be called sunblocks instead of sunscreen. Now they use more of the term mineral sunscreen. But the rays of the energy of the UV light comes in and it bounces off the skin. Those are the safer. They are the most effective. They're the best for sensitive skin, but they tend to be less elegant. So that's why patients don't like it as much. There are a few of them that actually have become better and better. One of my favorite sunscreens is called Elta MD, and I have no financial interest in the company at all. I just mention it just because, although it's a very expensive sunscreen, tends to be in the 30s. It is a great mineral sunscreen that does not feel as heavy, and it's a little bit more elegant than most of the other sunscreen. But Aveeno Positively Mineral is another sunscreen that is actually quite good and protective. Sunburn is another one. So just look for those in the label. Look for zinc oxide, titanium dioxide. In my opinion, those are the best sunscreens. Then there are the ones that are the chemical sunscreen. Those are the most common ones that you see. The ones that they tend to be Cooper, it's many different brands now I can think of it. But anyway, what they do, these type of chemical sunscreens, they absorb the energy through a chemical reaction. The energy of the sun comes in and the molecule just flips, and that absorbs the energy from the UV. And they usually contain ingredients such as oxybenzone, avobenzone. Some of these chemicals have become quite controversial about if they do cause cancer, if they kill corals. And so that is still a debate out there. And in fact, Hawaii does not permit any some sunscreens that contain the oxybenzone products. So in my opinion, mineral sunscreens, if you could get one that is elegant, that's the one that you should stick with. The SPF, we normally, dermatology would recommend an SPF that is 30 or higher, and that's the sun protection factor. What it measures is the UVB protection only, not the UVA. So what they do is that they apply the sunscreen, and then they measure how long does it take before it turns red. And the reason why is UVB is the one responsible for the painful sunburns, but UVA is more of a weaker energy wavelength, but it causes long-term slow damage to the skin, including wrinkles, including brown spots, and it leads to cancer, but in a more slow way than UVB does. Most of the sunscreens here in the US are very protective against UVB, but they're not great for UVA. And the reason why is because the SPF only talks about UVB. There's no great way to measure UVA. And that's why you need to look for a sunscreen that says broad spectrum, because that means it's also protecting you against UVA. And UVA is responsible again for all that chronic sun exposure, which is going to lead to premature aging, brown spots, wrinkles, and it could also lead to skin cancer. So the key points about this lecture, and we almost ready to wrap it up, is prevention. Prevent. Look for shade, cover it up, use your sunscreen. Early detection is key, so get your skin exams, do your self skin exams, look for board certified dermatologists or providers that are well experienced in the field of dermatology, and that way you could enjoy life and the outdoors safely, even more now that this weekend is Memorial Day weekend. So here are the answers to the quizzes for you that actually participated early on. So the most common type of cancer in human, is skin cancer. And then vitamin D is not produced by indoor tanning. And the reason why is the indoor tanning only uses UVA, not UVB, because UVB leads to burns. No one wants to tan and come out with a huge burn immediately after. So they only use UVA. Vitamin D gets only produced by UVB. UVA does not produce or leads the body to produce vitamin D. So that's why the indoor tannings, when the patients tell me, well, I'm doing it for the vitamin D, I'm like, you're wasting your time. That's not good. So that's one of the myths that I wanted to clear up. Indoor tanning is not safe. No tanning is a safe tanning. When you tan your skin, it means that your body received UV radiation and damage, and their body, your cells, are trying to protect themselves with a shield that it is melanin. And melanin looks brown. It does make it look nicer, but no tan is a safe tan. If you tan or you look tan, that means your skin suffered damage and is trying to protect itself. Question number 3 is, which is the most common type of skin cancer? Like I mentioned, is basal cell carcinoma. The third most common one is malignant melanoma, but it's the most famous and lethal. And the number 4 is which UV is the one responsible for sunburn, and it's UVB. The way I remember this back in residency or medical school, UVB for burns, UVA for aging. So the UVA goes through glass and it causes aging. So a lot of drivers will get more wrinkles. People that are close to windows will get more wrinkles. UVB will be blocked by glass. So you're not going to get a sunburn if your windows are closed. And number 5, and finally, what the chances is lifetime to get skin cancer, and it is 1 out of 5. 1 out of 8 is for breast cancer. And then anyway, in the picture, those are my 3 daughters. They know their dad is always telling them, look for shade, wear a long sleeve. And even my dog now is learning how to seek for shade when he lays down to rest. Finally, I wanted to say thank you, and we'll take any of the questions. And Dr. Pagalenti and myself will try to do our best to answer your questions.
All right, thank you, doctors. That was excellent. We do have a few questions that have been in the chat and sent directly to me. One of them is, are spray tans dangerous?
That's a good question. That is somewhat controversial. I myself don't believe yet that we have enough data to do the self-tanners. I do it myself. And the reason why is because I do believe that looking tan does make you look more fit, and it makes you actually look healthier. But the important thing about the self-tanners is they have 0 SPF. So you do not have any protection whatsoever from just looking tan. You will still get a sunburn if you go out there. As far as breathing the molecule when they spray it, I wouldn't, just like the sunscreen sprays, I would not breathe that product. But as far as we know, that it is not proven that it is dangerous, at least to cancer. At least we don't have that information right now. But to me, I think it is safer, much safer than outdoor tanning or regular tanning. So I would still encourage patients that if they want to look tan and they want to have a little bit of color, to go ahead and do the self to those tanning lotions or the sprays.
Okay, thank you. And then one in a direct message to me, what is an ulcerated melanoma?
Good question. An ulcerated melanoma is when the surface of the melanoma loses its top layer. It's usually a negative prognostic indicator. You don't want your melanomas to already present ulcerated, because it tends to change the stage of your melanoma. So if you are not ulcerated, you might have a stage 1A, but if you are ulcerated with the same amount of depth, you might be at a type 1B. So being ulcerated changes the prognosis and the stage of your melanoma. Again, an ulcerated melanoma, it's a melanoma that has stayed there longer, to the point that so much of the cells have grown that they have cut the circulation from the top layer of the epidermis, and that's why you create the ulcer. The other thing is melanoma cells or malignant cells, because they're malignant, they're not normal, they don't know how to grab onto each other well. So they tend to easily ulcerate. It's just an indicator that your melanoma, it's a little bit more advanced. That's what the term ulcerated melanoma is.
Okay, thank you. Someone asked, it just simply says, can surgery be done on melanoma? Could you expand on that a little more, the surgical options?
So any skin cancer, the primary modality is to remove the tumor by surgery. It can be done in a minimal fashion or anything, but the primary modality is totally remove the tumor. So surgery is indicated. Definitely, it has different methods to do it. Dr. Fernandez will enlighten with it definitely need a wide local excision for a primary tumor, meaning that you have to remove a normal skin surrounding the tumor to completely remove it so that it doesn't come back in the same spot.
Yes, and I agree. The primary treatment of melanomas are always removal surgical. That's the standard of care. the melanoma has to be removed, even if it looks somewhat advanced. The only time we don't ever remove, or we don't tend to remove a melanoma, if it's the patient already presents with widespread disease, where it has multiple nodules in the lungs or in the brain. Removing a melanoma from the arm is not going to change the prognosis of the patient. But in a single melanoma or even a few melanomas, always excision, wide local excision, means that depending on the depth of the melanoma, you have to go wider margins to make sure that it never comes back. So yes, surgery is still the standard of care and the primary treatment of malignant melanoma. Radiation is not a good treatment for malignant melanoma. And again, chemotherapy, although it has improved and immunotherapy has taken giant leaps, is still not as optimal or as curative as surgical.
Excellent, thank you. Next question, are clinical trials available locally or do I have to leave town?
I think CBCC is tied up with the UCLA, which are the premier centers in the country. They have tie-ups, and the clinical trials have been protocoled and approved by the National Cancer Institute. And they have satellite centers apart from Los Angeles, where they are approved and they follow the protocol and select patients for trials. And CBCC is one of the centers which actively participates in the clinical trials and contribute to the development of newer drugs and future treatments.
Yes, currently what they do is that they will give you the treatment that it is proven to show the higher survival rate. And those will be drugs like Keytruda, Opdivo. Those are names that they will try first. If everything else fail, here locally, like Dr. Pogalante mentioned, is we do have clinical trials at CBCC together with UCLA that they will enroll you in trials if everything else fails. So you don't always have to go to LA. There is actually satellite offices like CBCC is with big institutions like UCLA and others.
Okay, thank you. And this next one, can I get burned through clothing or is that a myth? Can I get sunburned through clothing?
Yes, and you can get sunburn through clothing depending on what kind of type of material it is. The clothing do not have to be UV protected all the time for you to prevent a sunburn, but it depends on the thickness and the material of the clothing. If it is one where there's like you could see through it with big holes, obviously those rays are going to get through it, and you could still get sunburn. But just the regular clothing that we wear, it should give you significant protection against a sunburn. Your ears or the other areas that will be sun exposed will probably sunburn a lot quicker than the rest of your body that is wearing clothing. So I always mention to my patients that say, well, but it's too hot for me to wear clothing. And I always mention, and I go back to the people that live in places like the Sahara Desert. You never see them wearing shirts and tank tops. And they wear all this long clothing, and it's not just for religious reasons. They learn that if you wear loose, light colored clothing covering your whole body, you actually will stay cooler than if you actually let the infrared rays, which are the ones responsible for the heat, to hit your skin. They actually will warm up your skin more if they directly hit the skin than if you wear light color, loose clothing. So I still will rely on clothing. I would say the amount of burn, even with materials that are a little bit see-through, will be a lot less than if you don't wear any. That's why we recommend hats, and that's why we recommend hats that will protect the top of your ears. I cannot tell you how many times I see patients with cancer on the top of the ear. Very, very common. The other thing I want to mention to you ladies out there, where your hair parts get sunburned all the time. Ladies tend to wear less hats than men. One trick that you should do is get a spray. spray it early in the morning or whenever you're ready to go out. Spray it. It's usually alcohol based. You rub it in with your hair, with your hands. Let it evaporate. Do your hair. Now your scalp has some sun protection. So don't forget the top of your scalp. I do hundreds of surgeries every year in ladies and right where the hair parts. So don't forget that area, lips, top of the ears, and where the hair parts.
Great suggestions. We have a question in the chat. Should gray moles be a cause for concern?
Say that again. I missed that question.
Should gray moles be a cause for concern?
Great. Well, not necessarily. Not necessarily. Gray. Gray moles are usually very, very uncommon. Usually, they are getting confused with another lesion that tends to be gray, which is called seborrhea keratosis. They like to call them barnacles. The color gray in moles is not very, very common. But any mole that is changing color, regardless of pink, red, or brown, is usually a concern that should be evaluated by a provider that has familiarity with the skin. I wouldn't just base it if it is gray, black, or red, because I've seen plenty of red melanomas. I've seen plenty of even light colored melanomas. Gray, just per se, it's a lot more common in a lesion that is called a barnacle, but I would say it's not so much the color. I would say it's a changing, like the E from the A, B, C, D, and E. How is it changing? Is it growing? Is it bleeding? Is it changing in color? Is it gray now, but it used to be white, right? Those are always signs for concern.
Okay. I think if you've got time, we've just got two more questions here. Can melanoma develop anywhere on the body, even in areas not exposed to the sun?
And that's a great question. And the answer is yes. So, although we always emphasize the importance of sun protection when it comes to malignant melanoma, I believe that the sun and the UV rays is not one of the only factors, or even the main factors of malignant melanoma. I do believe that there is a big genetic component to malignant melanomas. So this is why I always check on my new patients. I check on the bottom of the feet. So you could actually get malignant melanomas on the nails, on the bottom of the feet, the palms of the hands. You could get it in the back of the eye, ocular melanoma. You could get it in the roof of the mouth. You could get it in your private areas. Yes, malignant melanoma is not always sun-induced. Malignant melanoma could be due to just a genetic mutation that will lead to skin cancer and possibly death. So even on the scalp, that's also important to look through the hair and see if there is any suspicious lesion there. Hairdressers are trained to look for lesions that do not look right. They would not be able to tell if it is melanoma or not. Most of the time they come here and it's nothing to worry about, but they are trained with the license to look for lesions on the scalp. So yes, malignant melanoma could happen anywhere, even in non-sun exposed areas.
Okay, and the last question, how much does family history increase the risk?
Another good question. It depends on how strong the family history is. If you're talking about, having a mother and a brother, and then they also have other cancers associated with them, not all of them. There are a few types of cancers that are somewhat linked to malignant melanoma, like pancreatic cancer. So family history does increases the chances of you developing a melanoma. Again, it depends if it's just your mom or just your grandmother. Probably the risk is not doesn't go up very high. But if your grandmother, your mother, and then your brother had malignant melanoma, that is quite significant. Another thing that I think it doesn't get emphasized enough about malignant melanoma and the chances of getting malignant melanoma is the number of moles that you have in your body. If you have about 50 moles in your body, and that seems a lot, but there are patients that actually have more than 50, that really puts the risk at a very, very high percentage. I usually see those patients every 6 months because their back is dotted with moles. And I think that having a lot of moles really increases your chances of malignant melanoma. I think it is because there is already from genetically, you are creating those moles, and that's your genetics. And you also will have the genetics to produce a melanoma. Patients with multiple moles should always have it examined by the dermatologist. They should really, early on, when they see kids that are already having 20 moles, those kids should always see a dermatologist every 6 months to once a year, because the risk in those patients is quite high.
Okay, thank you for that information. I don't see any additional questions. So at this time, I just want to thank everybody for participating and remind you that this has been recorded, and everyone who registered will receive the recording via email in the next day or so. And I especially want to thank Dr. Fernandez with Comprehensive Blood and Cancer Center and Dr. Pugalente with Dignity Health for your time and for what you do in the community. We really appreciate you sharing your time and your information with us. And with that, we will say goodbye and have a happy, healthy summer.
Thank you.
Thank you, Sean. Thank you.
Thank you. Good job. Thank you.
Well done.